So thank you for joining our workshop, Advancing a National IEHP Integration Strategy. I'm Carl Flecker, Senior Manager of Policy Advocacy with WES, and my pleasure to serve as the moderator today. So our agenda is quite straightforward. With Joan's assistance, we're going to be sharing a few slides that will set the stage, and then we're going to move into a moderated conversation with our panelists. And at the last 15 minutes, we're going to have some Q&A. I'll be monitoring the Q&A for your questions, so please do use that box. But let me start with some introductions of our four panelists. Joan Atlin is the Director, Strategy, Policy, and Research at World Education Services. Joan brings over 25 years of experience leading and executing strategic policy, advocacy, and program initiatives. She's worked extensively to improve the access to professional licensure and workplace inclusion of internationally trained professionals. She served as the Director of Programs for the Toronto Region Immigrant Employment Council and Executive Director for the Ontario Association of Internationally Trained Doctors. Joan has developed and managed bridging programs and served as a Senior Program and Policy Advisor in the former Ontario Ministry of Citizenship and Immigration. Also joining us today is Joy Navarro, who's an IEN working now at Trillium Health Partners, where she is the clinical educator with THP's Extern Program in Nursing Workforce Development. Joy immigrated to Canada in 2014 and is a passionate and dedicated nurse who loves to see IENs grow to their full potential. Tyler Downey is the Secretary Treasurer for SEIU, Service Employees International Union in Healthcare Canada, a union representing 60,000 frontline healthcare workers in Ontario. Tyler was born in Regent Park and raised in the Jane Finch corridor and comes from a family of internationally trained health professionals. Naomi Alboim, currently a Senior Policy Fellow at the Canada Excellent Research Chair in Migration and Integration, and is a Distinguished Fellow at the School of Policy Studies at Queen's University. Prior to these occupations, she worked as the federal and Ontario provincial government for 25 years, including 8 years as deputy minister in a variety of portfolios. She's been involved in this issue of internationally trained professionals since 1986, and that's not a typo. So plenty of experience coming from all sides of the table here. Internationally educated health professionals, or IEHPs, have been making the news throughout the pandemic. The issues of licensure and labor market integration are very challenging for this cohort, and there's been a persistent set of barriers even pre-pandemic. While just and equitable labor market integration and licensure barriers are longstanding issues, it's important to acknowledge that there have been incremental advances, some of which were made in the early 2000s with the advent of bridging programs and the establishment of the Fairness Commissioner. But that progress has been stalled for a little over a decade now, actually coming close to 15 years. The pandemic has really put the issue back on the public radar, as is evident by these select headlines. Immigrants make up a significant percentage of our healthcare and social assistance sector, yet their levels of underemployment or unemployment, nearly 50% for those with health education obtained internationally, is a striking loss of talent. Is addressing not only underutilization, but also seeing it through the lens of race and gender. The percentage of immigrants working in the healthcare sector as nurses' aides, orderlies, or other patient service functions, particularly in urban centers, is extremely high, more than 70% in major cities like Toronto, Vancouver, and Calgary. Recent immigrants working in these jobs are educated. A quarter hold a BA, and nearly 70% hold a nursing degree. Women, and particularly racialized women, are on the front lines in our healthcare system. Nearly 90% of the nursing home workforce are women, and upwards of a third are racialized women, serving as nurses, nurses' aides, or PSWs. And one of the most disturbing stats that we've come across is from a report from the College of Nurses filed with the Ontario Fairness Commission in 2019. That year, Over 14,000 internationally educated nurses were seeking their registration to work in their field. And that same year, just over 2,200 became eligible to register. Something's not right. The Institute for Canadian Citizenship ran a social media campaign earlier this year called Equal Chance. The focus was on doctors, but their stories are not unique to the IEHP community. ICC produced several first person vignettes that put these numbers into a human perspective. The video clip is brief, just 90 seconds, but quite telling. So, Wes is working on a call for a national strategy to address the underutilization of the skills of internationally trained health professionals. And as the slide indicates, the bottom line is the needs of our healthcare system are growing. We're facing shortages of health professionals. IEHPs are a critical piece of our healthcare system and are central to solving Canada's healthcare needs. The skills and experience of IEHPs that they bring to Canada are extremely underutilized, and that underutilization is perpetuating race, gender, and human rights inequities. We need a strategy that looks holistically at the immigration, regulatory, and employment elements of a very complex issue in order to advance enduring and systemic solutions. What we're suggesting is a strategic approach to consider three key areas that underpin the larger problem of underutilization. Immigration, that includes a host of barriers from the immigration status that can impede access to bridging pathways. Licensure, which includes costly, lengthy, not transparent processes that often stymie IEHPs as they attempt to re-enter and advance in their careers. And employment, referring to advancing inclusive and commensurate employment opportunities for IHPs that do not perpetuate race, gender, immigration status segmentation of health professionals. Such a strategy is going to require the engagement of a number of key stakeholders. The list is long, but not exclusive. Let's cut to some questions. Joan, you're up first. Wes is proposing bringing together the stakeholders in the healthcare ecosystem as a strategic step to help end underutilization. Hasn't this approach been tried before, and what would be different this time?
Well, in some ways it has been tried before. I want to just refer to my own experience a little bit here. Back in the early 2000s, I worked with an association of internationally trained physicians here in Ontario. And we were one of the very few IMG or International Medical Graduate Groups, the only one that was invited to participate on the Canadian Task Force for Licensure of International Medical Graduates. And that was convened by Health Canada back in 2002, and it reported out in 2004. And that task force made recommendations around assessing and preparing IMGs, helping them navigate the system, but it didn't address the core issues of barriers in the pathway to licensure, which for doctors in Canada is primarily the Canadian experience issue, which generally means getting access to residencies. So that task force kind of skirted around what the really core issues were. And when I think about who was at the table on that task force, the medical regulatory bodies were there, the ministries of health, Health Canada, of course, were there, the medical schools were there, and those are all absolutely, obviously core actors, and the regulators have an absolutely pivotal role in this in terms of setting standards and public safety. But who wasn't there at the table? There were no healthcare employers at that table discussing how to resolve this issue. The provincial hospital associations weren't there. The long-term care associations weren't there. Community clinics, family health teams, the representatives of underserviced communities who had been contacting our organization constantly to say, we need doctors, we'll find a supervisor, we'll create a, let us work with CPSO for provisional license. None of those players were at the table, and nor for the most part were the voices of internationally trained physicians who had gotten their licenses, who'd made their way through the system, and who would have had a lot to contribute to the conversation. So that's the way in which I think there's a different conversation that could be happening now and that really needs to happen now. These are really complex problems, and there are a lot of stakeholders involved. And I think that we're only ever going to really be able to move towards better solutions by putting all of the players who have a direct interest in the solutions at the table together and mandating them to come up with a collective strategy. This, in thinking about this, it really made me think about in the nonprofit and the social impact sector now, we talk a lot about collective impact. And that's based on the idea that you put all of the key stakeholders at the table together and they come up with a shared set of goals and a shared set of outcomes. And then each player takes the actions that are within their sphere of influence or authority so that you get this set of mutually reinforcing activities that can actually move the needle towards those goals that have been set together by that collective of players. And we've never really truly tried that approach to address the underutilization of immigrant health professionals before. It happens really at the tables of the bridge programs who have to pull all those players together, but it doesn't happen at the system level. And this really feels like a now or never moment to try to make that happen. And that's why we're beginning to frame this in terms of a national strategy or a national framework, because the issue really involves the disconnects between immigration policy, health policy, licensure, employment, and these do cross jurisdictions, even though licensure in the most direct terms is a provincial issue. But a national strategy or framework could potentially take us to a broader conversation about health human resources and start from that reality that IEHPs are core and always have been to our health human resource strategy in Canada. And that really connects the dots between immigration policy that brings in health professionals and then the series of things that happen afterwards in terms of licensure, access to additional education or bridging, and employment. And so there are interjurisdictional aspects of the problem. And of course, people move between provinces. If they can't find a pathway in Ontario or Alberta or Quebec, they will go elsewhere looking for that pathway. And I think Joy is going to share some of her experience with that herself. So I think it really is about finding a way to have a bigger conversation about this issue that starts with the needs of our healthcare system and how we need it and has all of the right players at the table.
Thank you, Joan. So that's really interesting, both the prior history that you spoke to, but I'm just interested in getting some quick feedback from Naomi, Tyler, Joy, any one of you who may want to just respond to that notion of collective impact and approaching this from a multi-stakeholder approach. Any quick comments from your perspective before we go back to Joan?
I agree with you, Carl and Joanne. I think it's the right area where we need to be targeting on, given that there is so much discrepancies on the expectations on these IEHPs. As Joanne said, it is we have to target it as an immigration problem, as a Ministry of Health problem, as a regulatory body problem. I think this is the right perspective to look at things.
Thank you, Joy. Okay, maybe that's a good segue, Joy. Can you tell us a little bit more about your experience as an IEN coming to work in Canada? What went smoothly and maybe what didn't go so smoothly?
Yes, my story was actually a success story, and many of my colleagues or my classmates were not so fortunate as I was. So I came to Canada in 2014, and I started my licensure process 2 years prior to coming to Canada. So at that time, things were a little bit different, but for an average IEN to process the license and to obtain it, it almost took like 2 years. But right now, the process has changed. It almost takes you somewhere between 2 to 5 years. So that is a long time to wait for a professional who comes as a skilled worker with lots of background, lots of education, lots of experience, and then you can't work for the next 2 to 5 years. So that's a lot of burden on them. But for my case, after 2 years, I was able to get the license. My obstacle came because of I wasn't able to find a job because I had no Canadian experience. So for employers to see that I am a valuable asset to their organization, it's a real mismatch, I should say. I'm not exaggerating. I used to wake up every morning and apply for like 10 jobs per day. So at the end of 40 days, so after my 400th job application, I got my first interview for a casual position. So I'm very grateful that somebody, looked into my resume and liked me and they gave me the opportunity. But there is a real mismatch on what the employers are, willing to take in. Um, uh, so as I said, I was the very fortunate ones because my licensing process was a little bit better than the others. Two of my colleagues who kind of had the same, we actually studied in the same program. We had like similar kind of like work experiences, and they also applied for licenses as me in the same process through the same Ontario Skilled Worker Program. But then when it came to the license, one of them was given an RPN license by the CNO, and the other one said, no, you had to go back to school to even get a RPN license, while I got my RN license. And then, so my colleagues actually showed my case to CNO, and they said, this person had similar kind of experience, and they, had to appeal to CNO, and CNO gave them the license. So it's just a workaround. I don't know why CNO does that. But anyways, the skilled worker category of immigration, that's what I wanted to talk about. So it brings a skilled worker into Canada, but it actually doesn't tell them that you might need to go back to school in order for Canada to consider you as a skilled worker. So there is a discrepancy there. So nurses are expected to land here, process through their documents. It takes up to 2 years for CNO to go save them. You might need another 6 months to 2 years of schooling for even to be considered a nurse here. So where is that happening? So why are we coming in as skilled workers and not being provided the opportunity to prove ourselves as skilled workers? So where is that happening? And also now we have something called the National Nursing Assessment Service, which assesses the credentials, the work history, my registration in other countries and everything, and prepares a report. And it sends to CNO. The NNAS is actually saying, okay, this person's degree is compared to, the BSN program in Canada. But then the CNO does not recognize that. So why is there discrepancies here? It is a national level organization and we are a provincial level organization. Why are they not saying, okay, this is equal to that? Why are we still expected to go back to school?
Thank you, Joy. You're putting your finger on pieces of the puzzle that are not well connected, but need to be better connected, which is addressing, coming back to Joan's approach about a multi-sectoral approach and looking at the different buckets of relationship. I'm going to come back to the points that you're raising. I want to bring in other folks into the conversation. Tyler, why is SEIU interested in the struggles of IENs and other IEHPs?
Yeah, thanks, Carl, for the question. Hopefully folks can hear me okay. We're a union that represents a very diverse membership. And what we've found and what we've continued to track is this reoccurring recruitment and retention issue that is prevalent in the healthcare system. We believe it's insufficient with what's going on right now. And just to give you some data to support my points here, we know that in long-term care, there's about 35 to 40% turnover rate every year in the sector. Part-timers are probably 3 more times likely to leave the workplace than full-time workers. In home care, it's even worse. It's about 30 to 60%, depending on the agency that folks work for. And so what does this lead to? It leads to staff in those settings feeling overworked due to understaffing. It contributes to the high turnover rates, the physical and mental burnout of our membership. And so we want to be a part of the solution in trying to address these challenges. And we believe that enhancing recruitment efforts through IENs and IEHPs are part of that solution. And so that's why we're interested in, exploring how we as a union can participate in the solution for this very, very concerning issue.
Thanks, Tyler. That's great. So it's not just patient concern, but it's actually the welfare of the workforce itself. And for your own members. That's an interesting point. So you're also engaging pretty regularly with employers, and Joy just touched on this earlier as well. Uh, in terms of sending out resumes and looking for employment, in addition to dedicated and passionate, I would have to ask perseverance onto your resume, Joy. 400 applications out there. But Tyler, what are employers saying to you about the issue of staffing?
I
Where
mean,
are they at?
Yeah, so generally speaking, we're naturally devoted to raising up standards and opportunities for all healthcare workers, especially given the demographic makeup of our membership. However, when it comes to collective bargaining, staffing is somewhat disregarded by employers at the table. And so it's part of what we believe is an opportunity to have further discussions with some employers on how we can become part of the solution, finding as an organization to help with this very concerning issue as it relates to retention and recruitment. But it varies from like employer to employer in terms of who is really taking a look at this issue seriously.
Thank you, Tyler. Joan, I want to come back to you if I can. Wes has framed the underutilization problem in three broad areas. Immigration policy, we've heard about that. Joy's given us a very specific example based on her experience. Then there's the whole licensure and registration process barriers. And Tyler has hit on something about the challenges in the labor market integration of IEHPs, as also supported by the slides that we presented. So can you expand a little bit on your thinking about how a national framework might work, given the overlay of a subnational context, the provincial and territorial jurisdictional issues, where the regulatory bodies are located and what governs them, the many stakeholders that are involved. There's a lot of complex pieces at play here, but can you walk us through a bit of your thinking?
Yeah, thank you for the question, Carl. We don't have it all worked out. And as I said before, in terms of what a national strategy or a national framework or a national and provincial would look like. As I said when I was speaking earlier, what we're really trying to do is create a bigger conversation. In some ways, get out of some of the minutiae into a bigger conversation about how do we connect the dots and actually create a more systemic solution. So, the first piece that you mentioned, we were talking about immigration, licensure, and labor market. On the immigration side, one of the first problems that you come up against every time you try to have this conversation is the question, how many internationally trained health professionals are there in Canada? No one actually has an accurate answer to that question, including IRCC, in part because people come into the country, and we've heard, Joy just spoke to this, in different ways, internationally educated health professionals. Those who come in as permanent residents, yes, are asked what their intended occupation is, although whether they ever get back to that intended occupation is a question. There are thousands of nurses who've come into the country through temporary work programs, as through the Living Caregiver program and in caregiver roles. They're not registered really on the radar as internationally trained nurses, as health professionals when they come into the country. They may be captured by the census later on. And then increasingly, we're hearing about, particularly for internationally trained nurses, but I expect this is probably true in other professions, people coming as international students, those who can afford to pay international student fees. We're hearing internationally educated nurses coming to take a gerontology program at a college, because that will ensure that they get clinical hours and don't lose their recency of practice. So they're not really captured either as part of that potential workforce. And they're people who would need then to make both of those categories I just spoke to would then be caught up in this transition from temporary to permanent status. As we know, the federal government recently had a large transition program from temporary to permanent with 3 streams, one of which was healthcare. And the healthcare stream is the one stream that was very undersubscribed. So that transition isn't working for people from temporary to permanent, even in the healthcare fields where they're most needed. And also, as I said before, people move. People will move to between provinces to wherever they can find the opportunities. So for instance, not too long ago, Manitoba announced a grant program for internationally educated nurses to help them pay the costs to get licensed. Within a week, they had more than 1,000 applications to that program, and we heard of nurses from Ontario who were looking to go to Alberta to take advantage of that. Now, the Ontario government has recently announced something somewhat similar, particularly focused on the long-term care sector. And last week, the Ontario Minister of Labour was quoted asking the federal Minister of Immigration to increase provincial nominee numbers for Ontario for essential workers, including healthcare workers. So, we may have more numbers to bring in healthcare workers under the PNP, but if we don't have a system to catch them and ensure that they can get licensed to practice in pretty short order, then we haven't actually moved, we're no further ahead, even if we create those PNP spots. So that, that's just one example of how all of those pieces tie together across jurisdictions on the immigration side. On the licensure side, there are a number of issues where, while licensure is provincial, as Joy just spoke to, the licensure is provincial, but many of the assessment bodies are national, so that the actual process crosses both provincial and national bodies. And there are solutions out there that have been established, that have been tested, that have been tried across Canada and internationally, that could be scaled up, scaled up, and invested in both nationally and provincially. And so, as I say, what we're really looking for is both a national framework and the provincial solutions in a way that, because the disconnects are really leaving people hanging in our system currently, because we don't really have a system. We have a large, complex web of actors that IEHPs really need to sort through for themselves. And so if we take a systems approach that puts all the players at the table and then maps the journey, not from a government or a regulator perspective, but maps it from Joy's perspective, maps her journey as an immigrant, and maps it from the perspective of health system employers who need Joy at the front lines working, then we have the potential to identify all of the pain points along the way and hopefully have all of the players at the table who have the opportunity to weigh in on the solutions that they have control over. And as I said, I think what's missing isn't the solutions, because there are technical solutions that have been tried and that work. There are solutions around Canadian experience. There are solutions around a lot of these pieces. What we need really is the political will to take that more systemic approach and to create the accountability frameworks. We have accountability frameworks too, the fair access legislation, the pan-Canadian frameworks, and they haven't quite gotten us there yet.
Okay, thank you, Joan. Naomi, you've been listening quite patiently to inputs that have been here, and typo aside, you bring a wealth of wisdom and experience to this. So I'm curious, Wes is talking about looking at three buckets, 3 areas: the immigration, licensure, labor market integration. In your opinion, are these the correct underpinnings to address newcomer underutilization?
I think that they are. I would expand them, and I'll tell you a little bit what I mean about that.
Please
And
do.
I would again emphasize the relationship between them, as Joan has described and as Joy has described. Dealing with them in individual buckets, I think, is potentially problematic. But I think, Joan is talking about bringing everybody together. And I think that that's really important. A kind of real multi-stakeholder approach to this is important. But for ease of dealing with it, having those sort of 3 buckets, I would just do it with overlapping buckets rather than distinct ones. But I think that's helpful. But let me just describe a little bit about what I mean by expanding them. So immigration policy is certainly important, but I would say that the implementation is just as important as the policy. And often things fall apart in the implementation of the immigration policy. So I don't know how many of you had the opportunity to read this full page in the Toronto Star this weekend that described the stories of two internationally trained nurses who came here as caregivers. And they have met all the certification requirements, all the registration requirements, and now they're just waiting for permission to work, which is just unbelievable to me. They came here with permission to work as caregivers. Those work permits have now expired. They have applied for permanent residency, but the backlog for permanent residency is so deep and so big, that they can't, and they had a closed permit just for an employer-specific temporary foreign worker permit, and they're applying for a transitional open permit until they get their permanent residency, and it's all just collapsed. And so much time has gone on now that they likely will miss out on the years of practice that they need to actually be registered. So the implementation problems are just as significant, and in some cases, I think more significant than the policies. The other thing I would say is it's not just federal immigration policy, but also provincial immigration policy that has to be looked at. I am thinking, and I know that Joy, you came in through the provincial nominee program, but I'm just thinking about if there were a really, if the provinces had more meat in the game, is that the right expression? But if they were actually responsible for the recruitment and selection of internationally educated health professionals, given that most of the tools are in fact in provincial jurisdiction, maybe they would actually be more committed to seeing the people that they selected to serve the labor market needs and the healthcare needs in their provinces. Maybe they would actually do more about it. So I'm actually thinking about whether internationally educated health professionals should come in through nomination programs by provinces who can actually make it happen, given the tools and instruments that they have available to them to help people actually get certified. So that's for the first point, which is immigration policy, maybe not just policy but implementation, and maybe not just federal but provincial immigration policy. The second issue is just as complicated, I think, and licensure obviously is a very big issue. But I think it's a mistake to focus just on the regulators. And but what I mean by that is so many of the prerequisites that are necessary for the licensing process are not controlled by the regulators. So, you know, there is everything from making sure that people have the information they need before they actually come, making sure that there is a competency assessment that identifies gaps and refers them to where they can fill those gaps in a way that will then be recognized by the regulators. Looking at occupation-specific language training providers, because they have to have that language to pass their exams. Looking at specific bridge training, that's the education system, not the regulators, so they can get the courses that they need to pass. Having the preceptors, enough preceptors available to actually oversee their clinical practice requirements. Having employers available to provide the work experience that they need in order to then be registered. Having mentors. I mean, all of those things are not the responsibility of the regulators, but are absolutely critical for the regulatory process to be successful for the internationally educated health professionals. And the third piece, which is the labor market integration, I think two things there. It is critically important, and too often, as Joan has said, employers have been left out of the discussion and left out of the conversation, and they have to be really, really central to the conversation. But I think it's not just the end of the pathway, i.e. they're employed and everybody lives happily ever after. I mean, the issue really is every step of the way, what is the role of employers in terms of identifying the needs, in terms of providing the supervised placements, in terms of providing the workplace opportunities that will lead to licensure, perhaps, shadowing to facilitate laddering between various levels in the health sector, providing mentors. Employers could decide to provide their employees as mentors to people coming in, and maybe providing incentives for employers to participate in this exercise right from the very get-go is something that we should be thinking about. So yes, I think those three pillars, but interconnected and more broadly defined.
Thank you, Naomi. Sounds like Joan and Naomi, you've outlined some broad frameworks and really helped fill in some pieces. I'm hearing that some of this is about practical wage and working conditions for healthcare workers. I want to swing back around to Tyler. What are the three things that you want to see a human health resource strategy post-pandemic include? What are your priorities, Tyler, coming from SEIU, given what we've heard from everybody so far?
Yeah, thanks, Carl. I think for us, it starts with more stability in the form of full-time positions across the healthcare sector. What we know now is 52% or just above half of the positions in LTC are part-time or casual. Most of our members work multiple jobs just to sustain some type of decent standard of living. Home care, you're probably in and around 60% of the positions being part-time. And so we think it's the starting point is the stability in the form of full-time positions. I think Naomi touched on, subsidized educational offerings from employers, and government to train IENs so, they can practice nursing in Ontario upon arrival. We've heard many stories of our own members who are IENs or internationally educated health professionals that struggle. Right, they come to the country with the hopes of being able to practice, but then once they get employment, they're in this cycle of trying to save enough money to go and get that the necessary courses covered, and so the bridging program, making that more cost effective for internationally trained professional, so that they don't. Have to worry about that saving enough to finance their education. So I think those are the two. So stability, the subsidized educational opportunities through government employers. And then I think number three, more involvement from and support offerings from the CNO, the RNAO, and WeRPN. Those type of opportunities that they could provide as an additional resource to IEHPs would be, I think, helpful.
Thank you, Tyler. Joy, I want to come back around. Clearly, underutilization has been an important theme here. And I suspect, you told us just how every day that impacted you. And we often hear about this in very, economic terms, the amount of talented labor that we're missing out on. But there's a human cost to all of this as well. And I'm wondering if, in your experience, in your conversations with other IENs, in your role at TPH, can you comment on what that underutilization looks like and feels like beyond just the economic loss? These are human beings who've dedicated their lives to a particular profession. And 2 years, that's a long time. And that's the success story.
Yes. Carl, so before immigrating, these are healthcare providers who have been in their professions, say 5 years, 10 years. They're coming to this new country. Not only they are new to this country, but they are also in search for a new job. It might not be even in healthcare. I'm recently recruiting more nationally educated healthcare professionals into our organization. When I see the resumes, they are in food processing. They are, working in the kitchen, working as forklift operators. So, like, they are, they lost themselves, right? They have been a nurse or a physician for the past 10 years, and you come here and, you're a scheduler or something. So it's losing that self-worth and looking into, what I need to do to make my ends meet instead of what fulfills me. I think that's the human component we are missing.
Thank you, Joy. That's a very good point for us to keep in mind. I'm going to just encourage folks who are out there listening to use the chat or the Q&A function to tap in their questions. We'll turn to some of those in a few minutes. But I want to just come back around. Joan, you've heard some very interesting responses from Naomi, Tyler, and Joy. Is there something that's percolating that you want to respond to?
Yeah, it was interesting. As I was listening, I was thinking of a conversation that Carl and I actually had just very recently with some folks in the Ministry of Labour here in Ontario, where there is some proposed legislation around Canadian experience and timelines and other licensure issues for non-health professions, because the Ministry of Labour and Skills Development is responsible for the non-health professions. The health legislation is under the Ministry of Health. But we were talking about the connections between the stakeholders, the labor market, and how to, even in the consultations for those other professions, would it be possible within one province and one ministry to test out that kind of multi-stakeholder approach? And they were interested to think about, what if we didn't, we're talking about timelines for how long an application takes and about replacing Canadian experience, but what if we talk to people other than the regulators? Because to Naomi's point, you can't fix any of those problems unless you have the educational system and the investments in the educational system, and the employers and all of the other pieces in place. It's not, the regulators, the regulatory bodies, are in this, I think sometimes in the IEHP world, they get painted as the bad guy. They're in this in good faith to do their jobs, and they can't do their jobs without support to all of the other players who are required to make the process and the system work. And so, thinking about it also made me think about, we've been participating in the long-term care sector staffing strategy discussions here in Ontario, and I've been sitting on a task force around bridging and laddering for PSWs, RPNs, IENs, and the conversation there about preceptors, for instance, or about just the strain on the sheer volume on the regulators and the employers saying, we want to be involved in this. But then we need, if our PSWs are now going to do training to become RPNs or RPNs, RNs, we're going to have another hole in our system, and we're going to need some support on the HR side. So it's kind of, thinking more 360 about these problems, so that they're not just on the regulator to fix the specific problem, but we're thinking about all of the players who are engaged and what kinds of investments it would take to support all of the players. And I think about CNO, for instance, and that stat that was up on that first slide, 14,000 IEN applicants in a year. You need a call center, they have a call just to manage the inquiries. I mean, the strain on the regulatory system of managing this, that requires support and investment as well, I think.
If I could just jump in, I guess I'm maybe because I've been around for so long and I've seen a lot of things tried. I think some good incremental steps in some particular occupations or in some particular aspects of the whole process. So I don't want to not give credit where some credit is due in terms of some progress that has been made. But I'm just cautioning about the notion of a national strategy. I think the complexity is enormous, and maybe Joan, it's a national conversation on certain issues, but I think the strategies, some of them will be pan-Canadian. I like the term pan-Canadian rather than national for all kinds of reasons. I mean, when you come up with a national plan, a national strategy, whatever, it gets provincial backs up and gets, Quebec up, and maybe it's better to call it pan-Canadian. But I'm not sure, actually, that we're ready for a pan-Canadian strategy. I think we're certainly well overdue for a pan-Canadian conversation. But I think we have to acknowledge that there really are some very significant jurisdictional issues here. And, provinces are responsible for health. They're responsible for health human resource planning. They're responsible for the regulation of professions. They're responsible for post-secondary education. They have all the devolved funding from the federal government for labor market training. They are responsible for workplace standards. They're responsible for occupational health and safety. I mean, all of these things come under provincial jurisdiction. And I think that we saw with previous exercises of, the framework, the pan-Canadian framework for the assessment and recognition of foreign qualifications that was, directed by the federal government in 2010, that it wasn't terribly successful, frankly. And I think it wasn't successful for a whole lot of reasons, which, I can go into or not at this point. We probably don't have time. But I think basically the provinces and the regulatory bodies across the country had very different capacities and were very different at very different stages. And when the federal government tried to orchestrate with the provinces a national framework and a national plan, everything came down to the lowest common denominator, because they had to satisfy the capacities of really small provinces or small regulatory bodies. That was number one. Number two, I think they really tried to impose things, which didn't work. I mean, they have to come sort of bottom up. Most importantly, they only dealt with regulators, not with all the other stakeholders. And it would have been very difficult for them to deal with all the occupations and all the stakeholders. So they just said, okay, we're going to deal with so many occupations and only the regulatory bodies. And you can't do this with just the regulatory bodies. It didn't motivate the national framework. And this, I was actually involved in the evaluation of the framework in 2012. And the national framework didn't motivate, but it validated the activities of the various players that they were already committed to doing. And there's a difference there. It reinforced the work that they needed to do. And what was really interesting, that it wasn't the framework that got things done, it was financial incentives. There was, the FCRO and the FCRP. The FCRO was a Foreign Credential Recognition Office, which was part of CIC, and the Foreign Credential Recognition Program, which was part of HRSDC at the time. And it was the program that had money. And the money was what they used as an incentive to try new things at either a pan-Canadian basis or at least more than one province to get some collaborative initiatives going. And those actually did result in some change. So, if I think if we're talking about a pan-Canadian approach, and if we're talking about, let me talk about governments. If you think about what the federal government in an area that it does not have jurisdiction on, but what a federal government can do in this area, they have a lot of instruments, a lot of policy instruments, a lot of tools that they can do. First of all, they can make sure that their policies and their programs have some coherence in this whole area of, trying to achieve the objective that we're trying to achieve here in terms of internationally educated health professionals. Number two, they have a lot of capacity in terms of public awareness, information provision, whether it's in their embassies abroad, their website, doing public education campaigns, doing pre-arrival information through CIP, doing orientation, pre-arrival services and referrals. So all of that bucket, they could legitimately do. Another bucket, a big role for the federal government is convening.
Yeah.
And they have the capacity to convene, and they've done lots of multi-stakeholder convening stuff, some very successfully. And that kind of convening role, providing the people want to be convened, can be a very effective instrument. The other thing is spending power. The federal government uses spending power in areas over which it has no jurisdiction. And we see that all the time. And health is one of them. And they could put some big buckaroonies in this if they wanted to, that would actually unclog some things, provided that they let the provinces and those with the jurisdiction to actually do what was necessary. So use the money, but let others do, and let others tell you what the money should be spent on.
Thank you,
They have
Naomi.
taxing power to provide incentives to employers to do all kinds of stuff. They have procurement power. They can procure insurance, across the country to protect employers who are afraid of providing work opportunities to not fully registered people. They can compile and disseminate best practices. And perhaps one thing that we never talk about that I think is so important, they can really negotiate mutual recognition agreements. How
Yes.
many people do we have coming from the Philippines who are now practicing? We know the system in the Philippines. Why don't we just have mutual recognition agreements and have nurses from the Philippines hit the ground running? And the federal government can do that in terms of MRAs.
Thank you, Naomi.
I'm going to stop there.
No, those are all great ideas. And what I'm hearing is some really useful suggestions for a hybrid approaches between the national and subnational levels of government. It's good advice in terms of thinking carefully about the language that we're using, pan-Canadian, national strategy, national conversation. I'm also mindful that the moment that we are in the midst of this pandemic, and what's ahead in terms of the global shortfall of healthcare workers are two more pressing reasons to take this on seriously.
Absolutely.
I'm going to switch gears because there's a couple of questions coming through on the chat. Somebody is asking, are there any strategies to address the role of private agencies who are advising IEHPs, both in the pre-arrival and post-arrival settings, to work as personal support workers instead of pursuing pathways to professional practice? And a related piece on that is strategies to address the need for affordable childcare, because many IEHPs who arrive here are coming with young children, and the childcare responsibilities impact their career timeline. So two connected questions there. If anybody's got any input on those, that would be great.
I can start. I think in terms of the recruitment agencies or consulting agencies or immigration consultants who work abroad, this has been an ongoing problem, and not just with IEHPs, but in with every other group as well. And I think the only way to counter that, we can regulate people here, we can't regulate people abroad. But the only way I think to deal with that is to counter with really good information and really good, solid information. The problem is that unless we have really good pathways as alternatives to permanent residence and to, fairly quick licensure and registration, of course, people are going to come in through other mechanisms and, hope for the best. And, there are all kinds of motivations why, people are coming here for all kinds of reasons. And So I think we put a lot of effort on creating those good pathways and put a lot of effort in good information so that people aren't taken advantage of.
Thank you. It also comes to mind that in Manitoba, under the Temporary Foreign Worker Program, they attempted to regulate the brokers, labor brokers and ghost brokers, and put a nominal amount of money into compliance and monitoring. But as you say, Naomi, providing clear pathways, permanent pathways, is likely to be more effective. I'm mindful.
Oh, childcare, absolutely, absolutely, absolutely. And hopefully the national childcare strategy and the agreements that are being negotiated will benefit everybody, men and women, internationally educated health professionals, and everybody else living here in Canada.
True. And the Manitoba grant took a small step towards that in saying that some of those 23 or 26,000 could be applied towards the cost for pursuing the education, but the universal childcare is the bigger systemic remedy. Let's just do a quick round. Tyler, Joy, Joan, any final comments that you would like to share?
I think involving the employers is also very vital. So employers are not really aware of where these IENs are coming from and what is the registration process looking like and what are the hurdles they are facing. So having those conversations and helping those inside the system to, realize where they want to be and giving them the opportunities to achieve their potential is important, and it falls on the employers.
Thank you. Tyler?
Yeah, thanks. I think I just want to say that I think it's important for us to think through, and as part of the solution finding exercise, think about the experience of the IEHPs, like from the time they leave their country to come here to, I've heard stories from our own members who are IEHPs around having to leave their children and their families and having to come here to Canada and settle and migrate. And to what Joy was saying, look for that first job and to get their foot in the door. One of the members I spoke with last week was talking to me about her having to work at a factory for a number of years before she got her first healthcare job, just so that she could make some ends meet. And so I think, we should look at it really from a human perspective first, and what is that experience that IEHPs go through, so that we can come up with real solutions. I know there's a policy side, there's a structural side, but when you really think about it in a deep way, many of them are coming to this country and their labor is being exploited. And so is that the country that we want? Is that the representation that we want as a country? Because folks chose Canada as the country of choice, right? They could have went anywhere else. They said, we want to go to Canada for a better life, for a better living, for our families and ourselves. And so I feel like, when we talk about childcare and programs like that, we talk about, I think the question was around, pre-arrival and post-arrival. There should really be an emphasis on those type of supports, whether it's housing. So that's one of the things that we've heard as well, is some folks come here, they have no friends, they have no family. And so how do they begin to get connected to, whether it's community groups or peer groups or other folks that can support them in their transition? So I think those type of things are also important. And I just end on, Joy brought it up as part of her closing remarks, but the employers are definitely have to be a part of the exercise here, and they have a big role to play. There are some that are attempting to do things. We're still trying to find out what those details are. We want to help work with the employers, but the employers are definitely a big part of it. So once again, thanks for having us as a union participate in this panel.
Thank you. So we've heard some really wonderful things about the need for looking at this from a hybrid perspective, necessity for a multi-sectoral approach, to look at solutions orientation, that we need political will, systems-based thinking, and keeping people front and center in this thinking. That's I think to me is one of the big takeaways. Joan, do you have a final comment?
really just to thank the people who've joined us, because I think we got all of those perspectives in this conversation. What we were hoping for was to get out of the weeds a little bit into kind of thinking strategically. It's been for people, many people who've been involved, and I'm sure many of the people who are listening to this conversation have been involved in this work for many, many years. And it has surprised me that even in the moment of the pandemic, we haven't made the kind of leaps forward and taken the kind of innovative steps that I would have. If you'd asked me a year and a half ago, I would have thought a lot more would have happened by now than it has. So I'm really, I'm encouraged that people are willing to try to have this kind of strategic conversation to say, how do we? And Naomi, I really appreciate your thoughts and your input about the convening power of the federal government, and maybe that's really the the bottom line in terms of how do we change the conversation. Because if the pandemic didn't change the conversation, to me, the things that are, and I wouldn't say it didn't, it has, it's given us an opening and an opportunity. And to me, part of that is making this an a health human resource conversation. It's about the people, the IEHPs who, I love the way you just put that, Tyler, that people are choosing Canada. They're choosing to come here, and then we're tossing them aside. So if we make it that conversation, and we make it a conversation about health, human resources, and this huge underutilized resource, and how do we convene around a new and a different conversation, to me, that's what I'm taking away from today. So thank you all for participating with us.
And I want to thank all of the folks who've been patient with the echo chamber, the black box that is now Carl, and the excellent inputs. If there's no any final words, I'm going to close it down and have people enjoy the rest of the afternoon. Once again, thank you to our panelists. Brilliant insights, great experience, and we're not done yet. Bye all.
Thank you all.